So we're going to have a really interesting discussion today, and I'm going to keep the discussion hopefully confined to around 20 minutes. This is going to be on the basal ganglia, on the temporal lobe. I've been going through the different lobes of the brain just to give you some idea of the different hemispheres or the different lobes what they're responsible for. And so let me see here. We're going to go through the temporal lobe, okay? Okay, so just explain the temporal lobe, just a brief overview. Then we can go through the receptors and then the nerve fibers running through there. Okay, I'm all over it. Okay, where I'm at here. Okay, I didn't want to sign up for it. Let me just try the new chat. Okay. Temporal lobe. All right, let's get into it. Okay. Now, the reason why this is important, patient or anyone presents with certain sets of moods or type of behaviors, you need to have a good sense of what parts do what. And so you can sort of narrow it down at least to the hemisphere or the region. If you understand the hemisphere or the region, if you understand the blood supply, the nerve supply, and the receptors on those nerve bundles, then I think you have a really good idea of the routes you'll need to take to deliver the medications to these particular targets. And so we need to know exactly when we give the medication, we need to know exactly the endpoint of exactly where it's going to target it and what it's going to do. Otherwise, we're just guessing, right? If you don't really know the target of your medications. So here, the temporal lobe is one of the four major lobes of the brain, located on each side of the head. On each side of the head. This is really written so you can really understand it, below the temples and behind the ears. It plays a crucial role in several key functions, primarily related to auditory processing, memory, language, emotional regulation. Broca's area is over here. Here's this language, in this emotional area here. Below is a clear and concise explanation of temporal lobe. Its anatomy, function, and significance. Okay. The anatomy of the temporal lobe. First, let me show you what it looks like. Temporal lobe. Here we are, right here. So here we are right here. Remember when we looked at the networking, we was looking at the inner surface of the brain. Let me see if they have another. Okay, like this. This is the inner surface of the brain, and this is the outer surface. Remember when we were looking here, we were looking at the nerve fibers come up here. So when we were looking at the inner surface of the brain here, that's when we were able to look at the mesocortical pathway that goes along here. We were able to look at the mesolimbic pathway that goes along here. So in the inner surface of this brain, you can see that's where we have the networking. And this is the outer surface, like here on the outer surface of the brain here. That's what we have there. Okay, so the frontal lobe right here. Okay, temporal lobe. The temporal lobe is situated beneath the lateral sulcus, the sylvian fissure. Okay, let me show you here. The sylvian fissure here. I think this is it right here, right? I think that's the sylvian fissure right there. Correct me if I'm wrong. Sylvian fissure. Yeah, I believe this is the sylvian fissure right here. Okay. Which separates it from the frontal and parietal lobes shown above. The frontal lobe which is here. Yeah, the frontal lobe here, and the parietal lobe, which is here. And I think this is the Sylvian fissure right there. It's the part where the tissue sort of envelops on itself. It's a lobule. Okay. It borders the occipital lobe at the back. It is divided into several key regions: the superior temporal gyrus, auditory processing, language. Okay. The medial and inferior temporal gyrus, visual processing, object recognition, and memory. All right. The medial temporal lobe includes structures like the hippocampus and the amygdala. Hmm. Hmm. I kind of thought that the hippocampus was set apart from the medial temporal lobe, but the medial temporal lobe includes structures like the hippocampus, and that's we reviewed the hippocampus primarily for memory, and then the amygdala, the emotional processing center here, and this is simply just a subnuclei within the temporal lobe. Okay. Auditory cortex, located in the superior temporal gyrus, processes sound information. Okay, Wernicke's area. All right. Typically with the left temporal lobe. Wernicke's, yeah, essential for language comprehension and speech production. Remember Wernicke's encephalopathy? Yeah, temporal lobe area. Okay. The temporal lobe is highly connected to other brain regions, such as the limbic system. Yeah, I can imagine for emotions and memory, and the frontal lobe for decision making and planning. Can you see how it makes sense? Can you see how all of these lobes, they specialize in processing specific types of information, right? It does it in this cortex, and then it integrates it back into these centers that sort of process things. Okay, hold on 1 second. Just gotta send this text real quick. Okay, so you have the specialized centers that are specialized in processing only like one type of information, like the visual cortex only does the visual cortex, right? The auditory is only that type of information. And then it integrates it into these areas right here. So here, the temporal lobe is highly connected to other brain regions, all right, such as the limbic system. Of course, you're going to need to get emotions, right, and memory to your limbic system and frontal lobe decision making and planning. Key functions. Okay. Auditory processing. Yep. Language comprehension. Memory. Visual processing and object recognition. Hey Doc, how's it going? You're not on the stage yet, but how you doing, Doc? Hold on a second. So I believe I can still hear you. Can you say something, Doc, so I can hear you? So I think, let me see here. Okay.
So I know I had a good time. That's what I'm saying.
Oh, okay. Okay. Great. Hey, Faith, thanks for joining me. What I'm doing is that every day at noon for the students and for my patients, I'm going through the science behind psychiatry and neuropsychiatry. And so here, this is on the temporal lobe. And so I'm going through how it works, and I go through how it functions, the blood supply, the nerve supply. And then I look at the receptors, and I use the AI because it puts everything. Oh, it's amazing. It's amazing. So yeah, hey, jump in. Let me know if you want to be on if you want to be on active on the stage, or you can just contribute or you can just stay audio, whatever you're comfortable with. Okay.
So, how long gonna be this podcast? Hour?
I try to do these for the students around 20 minutes because they don't have enough time. So I try and keep it below 20 minutes for the students because they're not gonna watch it if it's like 45 minutes. So I'm trying to get it in for 20 minutes.
Yeah, no problem. I'm free now, So
okay, thanks for showing up, Doc. Okay. So here, visual processing, emotional and social behavior, olfactory processing. Okay, so let me just go through some of these. And so it's important to understand the function of this frontal lobe because when the patients come in with these type of issues, like if remember not really listening to what you're saying or not really able to comprehend or process what you're saying, that's a real issue. In order for someone to really understand what you're saying, that information needs to be encoded into their hippocampus first. And then those bits of declarative information is sent more to the prefrontal cortex to be rendered into some type of reality. But the thing is that if the thing you're telling the person never gets encoded in their hippocampus and sent for processing, it never gets rendered into the reality that you're trying to make. So you have a reality, you're talking to somebody else and say, please, can you get that? You said over and over and over. It's not getting into their system. So when they come up with a reality, it's a complete reality that's void of any of the items that you were arguing about or you're angry about. And this represents dysfunction in the parts of the brain and necessarily not the person being uncooperative or oppositional or defiant or anything like that. It's real. This language is about information processing. And if you are you have more awareness when you process, let's say 100% is the most awareness you're going to have, sometimes people can only get like 10% of the information you're saying. And if you don't recognize that they don't have the capacity to put more information into their system, then I'm not sure how you're going to develop a reality that's stable enough for you to actually communicate, that's close enough for you to actually have a relationship and communicate. So here, auditory processing, the primary auditory cortex, right? Processes sound information, including pitch, volume, and tone. All right, pitch, volume, and tone. Recognizing a friend voice or identifying a song. Remember, what is that syndrome? I know I got a lot of students around, so I know you call this out if I say it wrong. Capgras syndrome or something like that. I think imposter syndrome. It was the someone wake up with the type of brain lesion. They believe that they don't recognize their loved one's voices or things like that. I'm not sure if it's the same one, but I recall that. Here, the primary auditory cortex is here in the temporal lobe. Language comprehension, Wernicke's area, right, is crucial for understanding spoken and written language. Here, damage to this area leads to Wernicke's aphasia, where individuals produce fluent but nonsensical speech and struggle to understand language. This symptom I never get right. When patients present to me with Wernicke's encephalopathy, it's hard for me to pick that up. It's hard for me to grasp it when I see it, and so I usually make errors first. I usually think it's something else, and when things don't work out, I have to go back and sort of review this and try to look for these type of aphasias. Yeah, but when a person speaks fluently and none of it makes any sense, if it's fluent speech and you can't comprehend any of it, then we're talking about there. Here, memory, look, hippocampus, right? Medial temporal lobe, essential for forming and retrieving memories, particularly declarative meanings, objects, just the facts, not abstract concepts. Like you can't find love in memory. You find a chair in memory, right? A chair, your declarative meaning is a chair, not how you feel, your wishes or your ambitions. It's a chair, it's an object, something like that. Okay, so these cortex here consolidate memory. Okay, next we have visual processing and object recognition. Okay, I never get into these. Okay. Emotional and social behavior. Yeah. Here it is. The amygdala, located deep within the medial temporal lobe, regulates emotions, particularly fear and pleasure, and plays a role in emotional memory. And then olfactory processing. So here, I just wanted to go through a few. It seems like there's more information here, but left versus right. The temporal lobe exhibits functional lateralization. The left temporal lobe dominant for language, right? Speech, comprehension, verbal memory. I think that's one of the keys, aphasia for the left, right? And right temporal lobe involved in nonverbal tasks such as visual memory, spatial processing, and music perception. Yeah, right. Yeah, very interesting. And let me know if you have any questions, or if you want to make any comments. Just let me know, and I'll be able to sort of update things from there. But let me know if you have any other questions. And Dr. Rahman, did you have any? Would you like to be on here, or just a sound?
It's okay. I mean, I'm in the room, so no problem.
Okay, I didn't know if you're the type of doctor that hides all the time.
yeah. I can shut it off if I want. It's an option over here, you know.
Yeah, you have people who don't want to be seen. Okay, all that everything. Okay, but you're doing okay, no, Doc?
Yeah, I'm doing okay, you know.
Yeah, and I know I just dropped this on you like 5 minutes ago, but any comments about the temporal lobe or anything like that, and what you said?
Yeah.
Oh, okay, let me just introduce you. Me and Dr. Rahman work together. He's the medical doctor. I'm the psychiatrist, and we work as a team. And we provide very good care for our patients and our students, and education for our students. And so we're looking for ways to sort of improve our care, and so we're going to focus on educating our patients, and families, and the students. And so me and Dr. Ron, we work together, and we've been working together for a while. Hey, it's been a pleasure working with you, buddy.
Thank you. As long as you're with me, I'm fine with you.
Any thoughts about
a good team?
Yeah. Any thoughts about the temporal lobe and things like that?
Yeah, I know. I just had to do what receptor is the prominent over this? Dopaminergic or serotonergic? What is the most common over there?
I think it's dopaminergic.
Okay.
But let me just see, because we're going to go over the receptor profile. Let me just try that now. What is the See, I'm trying to make it useful for the students in the USMLE. So
yes, they have to familiar
things that they will find useful. And so let me just review this real quick. So guys, remember, in the temporal lobe, we went through the hippocampus, we went through all the cortex, we went through all of these lobes. Remember, the same concept applies. Glutamate is the main excitatory neurotransmitter. It's present throughout all the tissues. GABA is the main inhibitory neurotransmitter. Those are the main activation, deactivation, things like that. And then you have things like norepinephrine, serotonin, acetylcholine, alpha adrenergic receptors. And I would say those are very significant receptors, but those are primarily localized within the area. They're not generally well distributed throughout the body as glutamate and GABA. And so look here, when it comes to the temporal lobe, look, glutamate receptors. Right? Glutamate receptors, look, GABA receptors, right? And then here's our host of other receptors. Acetylcholine, look, attention, learning, and memory, right? The dopamine receptors. Remember, this amygdala and hippocampus, remember the dopamine, if we need to stabilize that mesocortical pathway, or if we need to stabilize that mesolimbic pathway, here are again, dopamine receptors in the frontal lobe also. Here we are again, serotonergic receptors. Cannabinoid receptors work here. I don't know too much about the cannabinoids. So any what do you so Doc, here are basically the receptors on this profile. So whenever I have patients who exhibit just frank agitation, rage, aggression, combativeness, then I sort of also view these as like emotional, like seizure-like activity in the emotional areas of the brain, but not the motor. Do you see it like that? I sort of see it like that hyperactivity is more like prolonged, seizure activity. What are your thoughts about that, Doc?
Now I know most probably the dopaminergic, that's why you want to have, so, and his language and all those things, important part of this area, so emotional and there, all those things. So I think it's important, so to know, that area.
Well,
About functioning.
well, I know you probably noticed this in my prescribing pattern that I started using dual mood stabilizer, Depakote and lithium.
Yes.
Extended release first thing in the morning. First thing in the morning, right? Have you noticed that?
Yes, I noticed that. Yes, both of the, yeah.
Have you seen the change over the years? Because I think I started that maybe like 3 years ago or something like that. Have you seen the change in terms of the acuity?
Yeah, I always have a question, but anyway, now you told me, so now I think yes. I was thinking, sometimes in the number of medicine you give patient, we're going to take it or not. So I always had a question: one is better or multiple is better? So if the patient know that they need that, yeah, it's fine, But most of the patient, they don't know how many medicine has to take. So that is the problem. So polypharmacy sometimes gets really problematic.
Yeah, well, actually, I'm glad you got a chance to meet me and my team, because what we try to do when the patients come in very agitated or combative, we really try to get them under control right away.
Yes, right. Stabilization.
And then when they get up in the morning, if they agree to take the long-acting Depakote and lithium, then basically those are loading doses. And so I'm trying to really get to a therapeutic dose around day number 3, because I know I'm trying to dial down. I feel like I'm trying to dial down that activity in their temporal lobe, because I don't want them to get up agitated, combative. Yes. And in the rage, because that's going to continue the same cycle that they came in the hospital for, So, and we do that sort of religiously in the morning, so they get there and get it started right away. Do you see a difference on the patients? Like,
yes.
Combativeness, they be nice and toasty.
Yes. But we have a problem with the young patient. But young patient is the problematic. They refuse. They don't want to take it. Then you get the problem. So.
Yeah. It's a challenge. It's a challenge. So let me see here. I'm gonna see about the blood supply. So let me see about let me go through this again. For glutamate receptors, I still use Namenda, because Namenda is very effective for decreasing glutamate activity. So if I have someone with a history of typically maybe a bipolar mixed disorder, combative, agitated, aggressive, I'll always see about adding Namenda if I can't get the agitation under control with the mood stabilizers and the antipsychotic medications. And so and I use basically Depakote and lithium to address the glutamate receptors. Mm-hmm. So Depakote and lithium will upregulate the GABA receptors. Okay, and our benzodiazepines can be used to treat GABA, to target activating the GABA receptors. So I think it's more of the A site of the GABA receptors where the benzodiazepines bind and they activate GABA, and GABA exerts that inhibitory tone, turning off all the activity in that in the temporal lobe. And here we also have the acetylcholine receptors. The acetylcholine receptors are very effective at helping increasing the person's sensorium. Improving attention, concentration, things like that. So the patients with the very severe schizoaffective disorder, bipolar disorders, I started putting on Aricept. So that I can activate that acetylcholine system, and that helps with the cognitive impairment. It helps decrease the agitation a lot, Doc. Aricept, yeah. And they have a new antipsychotic out that's based upon the same, targeting the acetylcholinesterase receptors only in the CNS, not in the periphery. Okay. So the new antipsychotic is a branded medication, but basically it works the same way as acetylcholine, as Aricept. Okay. Now we also have our dopamine receptors, the dopamine 1 through 5 receptors. Now remember, the typical antipsychotics primarily focus on the D2 receptor. So in these cases with temporal lobe, let's say epilepsy or agitation and things like that, if you give a typical antipsychotic, remember, it's going to help stabilize those pathways. It'll bring down the anxiety, but it doesn't target any of the other receptors here inside of the temporal lobe. So we have two strategies. When the patients come in initially, we want to deal with the risk, the danger, and that's when we'll put them on a typical antipsychotic. But then once they stabilize, we want to transition them over to an atypical antipsychotic. And the reason why is because the atypical antipsychotic targets acetylcholine, dopamine, serotonin, and norepinephrine. So with a atypical antipsychotic, you're going to get a broader range of receptors that are targeting things. Okay, so for the dopamine receptors, you can use atypical antipsychotics for these disorders in temporal lobe. Here, serotonergic receptors, right? So we're talking about antidepressants, SSRIs, right? Remember the selective serotonin reuptake inhibitors, that can be very effective in treating and stabilizing it. Cannabinoid receptors, these C1 receptors are metatropic receptors. Remember, these are the ones that result in gene expression. Remember, you have the gates that turn on and off due to charges and things like that, and then you also have the G proteins that actually code for products to be produced by the cell body, and then those products are then exported out the cell. So this is the cannabinoids here, neuropeptides like opioid receptors, hormone receptors, olfactory receptors. Definitely for glutamate and GABA, you can use the mood stabilizer Depakote and lithium. For acetyl, if they're diminished and SORM, very inattentive, unable to unable to focus, you can target the acetylcholine system with Aricept. And with the other receptors, after you stabilize them on the typical medications, then you can switch to atypical medications to get the broader receptor profile to target here. So any thoughts about this, Doc? And then I'm at 29 minutes, so I'm gonna have to go through the blood supply real quick because I wanted to keep it down. Let me just go through the blood supply real quick.
Temporal blood supply.
Okay, can you explain the blood supply? Can you explain the blood supply in the temporal lobe? So I'm not going through all this. Got 10 minutes over. So let's see here. Let me just go through the main supply. It's medial temporal artery. Right here, remember this circle Willis? Medial. Okay, let me get to this. Okay. Middle cerebral. Okay, here's the anterior cerebral artery, coronal. Cerebral, yeah. So here, middle cerebral. This doesn't show. Here's the circle of Willis here. So this middle cerebral artery here. This doesn't really show it. That's not a good design to show what we're looking at. Okay, so it's supplied by the middle cerebral artery. Okay, you can read this later. The posterior cerebral artery. Okay. The MCA arises from the internal carotid artery and is the primary supplier to the lateral and superior portions of the temporal lobe. So it's the middle cerebral artery. Okay. And here, the posterior cerebral artery. The PCA arises from the basilar artery. Okay, and supplies the medial and inferior portions of the temporal lobe. Okay, great. And you can read the other. I don't want to go in too deep into that. I don't think it's going to be on your examinations. So Doc, did you have any other questions before I go ahead and take some questions from the audience at all?
Go on. So I'm still, in the process. So if somebody had a stroke in the temporal area, so their language will be affected if it's in the left, and also the thinking. Their mind. What is mostly affected? Their memory or their thought processing will be affected, isn't it? If there's a stroke in the temporal lobe.
Yeah, when I see these type of issues, the communication is disrupted.
Yeah.
But then they seem to behave as if they're unaware that you don't understand what they're saying, and they go on talking fluently, and you don't understand what they're saying and stuff. And so sometimes it's been hard for me to sort of pick that up. But in these cases, and so in terms of that's what I would do as a psychiatrist. So from your perspective, what are your thoughts? What do you do from your perspective when these patients come in?
Their thought process will be like a concrete. It's just like not a not a variation in speech or whatsoever type of thing. They talk like different things, different time, different aspects, like all gibberish, whatsoever type of things. Or is just a concrete thinking or speech?
I'm sorry, repeat that again. I didn't get the last part.
If they had a stroke in temporal lobe, so what will be their language? It'll be like they'll be having like a word salad type of thing, or they're just talking stuff.
Or Would you also think of that? I sort of think of that more as a disorganized thought process.
Yeah.
So they present with more of a disorganized thought process when they come in with these temporal lobe issues. Yeah.
Especially strokes,
Sounds good. Okay, I'm at 33 minutes. I was only supposed to 2. Your camera is upside down, Dr. Rahman. Okay, okay, great. All right, so I'm gonna go ahead and sign off for today. Guys, if you have any comments, then you can just put them down in the comment section. I'll try and get back to them a little bit later, but I didn't want to go over too far since they're going to start watching my lectures, so I go too long. Okay, so thanks, Rahman. Thank you so much for joining the show. I appreciate it. Then we'll talk later, buddy.
What's the next topic tomorrow?
See, today, right after this, I'm doing another podcast on, check this out. So I'm... I'm about to start stuff. All right.
Okay.
No, I'm doing a series.
Keep me updated. You just text me hey, come and join.
You may want to join it. So I'm doing a series on narcissism as a network.
Oh yeah, that I need to. Yes.
So narcissism is not an individual. That's just the node.
Okay.
And that network is getting close to you. So the subject is on narcissistic black family cults. And I'm using the Jacksons as the first example of a narcissistic family cult. And I'm going to do several series on each one of members, like Michael Jackson and things like that. Like, I think your camera just went off. Michael Jackson, I guess that's the end of the show. Okay, until then, folks, I'll see you guys later. You have a nice day. Today, we're going to have our discussion on acetylcholine. And how very important the acetylcholine receptor and the acetylcholine networks are. They're very important. And in fact, as I mature and grow as a clinician, I'm starting to understand how important the role acetylcholine plays in how the symptoms are manifested, right? So acetylcholine is important for a lot of very important things in the body, such as things like memory, things like arousal, things like that. And we'll do a deep dive into the acetylcholine muscarinic network, and then hopefully I can give you an idea of how this network operates and how useful it'll be for you as a clinician. So So let's see. Okay, here, so I'm on the free version of Grok here. You can use any search engine. Here, explain the acetylcholine muscarinic network. Okay. The acetylcholine muscarinic network refers to the system of neural and physiological processes involving acetylcholine, which is the neurotransmitter, and its action on the muscarinic acetylcholinergic receptors. Look at this. Muscarinic, right? Acetylcholinergic, right? Receptors, right? Muscarinic acetylcholinergic receptors, right? This network plays a critical role in the central nervous system, the peripheral nervous system, and various psychological functioning, right? And see, this is why we want to know more about the acetylcholine for its impact on the central nervous system, and also, look, various psychological functioning, well-being, memory, attention and concentration, things like that. Those symptoms sort of give you a reflection of how well the central nervous system is operating, but it doesn't show you actually where the dysfunction is coming from. So when we talk about the CNS, we're talking about the specific targets in the tissue. And we talk about the various psychological function, meaning that the symptoms you have, the diminishing SORM, lack of awareness of the environment, things like that. Those are the psychological issues it creates. Below is a comprehensive explanation of acetylcholine muscarinic networks, components, mechanisms, functions, and significance. Before I get to this, let me tell you why this is so important. Let me look. Okay, here. Explain. So, Aricept is a medication that targets acetylcholine. It inhibits acetylcholinesterase, and that's the enzyme that breaks down acetylcholine. So that's the strategy, all right? Now, why would I use Aricept? Let me give you an example. Whenever you have patients with head injuries, okay? You can get damage from multiple locations with the head injury, right? And this damage can result in just diminishing SORM, lack of awareness of environment, fatigue, tired, there's difficulty thinking, and that's a result of the damage. And so that diminishing SORM is likely attributed to deficits in acetylcholine in certain parts of the brain, right? So somehow in the diffuse traumatic brain injury and other head injuries and things like that, the inflammation and things can lead to changes that result in a diminished amount of acetylcholine in certain very important parts of the nervous system. And so, of course, we're going to need to shut off the enzyme that degrades acetylcholine. Once we shut down the enzyme that degrades acetylcholine, then the amount of acetylcholine builds up in the synaptic cleft, and hopefully it's enough to start improving transmission along the acetylcholine muscarinic network. If we get more hyperactivity in that network, then we get more arousal, we get better attention, we get better concentration, we get improved memory. So in patients with diffuse traumatic brain injuries, you want to look at the acetylcholine muscarinic network, and if they're having difficulty with attention and concentration, impulse control, things like that, you may want to consider Aricept to increase that acetylcholine muscarinic network activity. But let me just show you a few studies that support the use of Aricept and acetylcholinesterase inhibitors in diffuse traumatic brain injuries and other type of brain disorders, including Alzheimer's dementia, right? So Aricept is also known as donepezil, is a medication primarily approved for treating symptoms of Alzheimer's disease, where it works as a cholinesterase inhibitor to increase levels of acetylcholine, a neurotransmitter involved in memory, learning, and other cognitive functioning, right? Um, in the context of traumatic brain injury, Aricept is sometimes used off-label to address persistent cognitive defects, such as it's sometimes used. I think it should be used more. And you don't. It's not really. Aricept is not really associated with a lot of different side effects, such as memory, attention problems, reduced processing speed, and this can occur to damage to the cholinergic fibers in the brain. Damage to the cholinergic fibers, right? That damage could have been caused directly by inflammation, right? Or direct damage, such as a traumatic brain injury, right? This off-label application aims to enhance neurocognitive recovery by boosting acetylcholine availability, right? Potentially improving brain metabolism and supporting functions like arousal, motivation, and REM sleep, right? On the studies on Aricept and TBI, including case reports, open label trials, and small randomized controlled trials, have shown mixed but generally promising results. I've had a lot of, but you have to use it specifically on those patients, but I've had a lot of results for this. For instance, it's been associated with improvement in short-term memory, sustained attention, and overall cognitive function in patients with a chronic TBI. That's true. That's true. Here, there's a PubMed citation. One pilot study found element enhancements in visual memory after 4 weeks of treatment. Another small scale study reported significant gains in processing speed, learning, and attention. So this is in the case of a diffuse traumatic brain, of a traumatic brain injury. Let me see. Okay, I'm saying explain Aricept, the use in Alzheimer's dementia, because remember, with Alzheimer's dementia, you get loss of those cholinergic neurons, right? And so we want to use donepezil or Aricept to shut off that cholinesterase inhibitor and stop the degradation of acetylcholine, so we can increase the constant titer in the synaptic cleft and therefore increase the network activity. So here in Alzheimer's dementia, let me just go through this mechanism again. Aricept is a cholinesterase inhibitor widely used to manage symptoms of Alzheimer's dementia, a progressive neurodegenerative disorder characterized by cognitive decline, memory loss, and impaired daily function. So the symptoms of Aricept really focus on those memory problems, and then you start to see them over time have a diminished awareness or diminished alertness, things like that. So this is why we use Aricept in this case. And just look at the what we use for. Again, inhibits acetylcholinesterase, the enzyme that breaks down acetylcholine in the synaptic cleft, thereby enhancing cholinergic transmission in the brain. It must have been listening to me, because it said the same thing I said. This temporarily improves communication between neurons, right? Helping to alleviate cognitive symptoms of Alzheimer's, particularly in the mild to moderate stage. You see this? You got it? Acetylcholinesterase muscarinic network hypoactivity leads to the symptoms consistent with Alzheimer's dementia, right? Patients with schizophrenia typically may, or substance abuse issues may have the diminished cognitive awareness and things like that, difficulty thinking, difficulty with their memory. Yeah. So even in the case of schizophrenia and bipolar disorder, you have to start looking at those acetylcholine networks to see what's happening there. And so Amenda can go a long way in these cases, okay? And we want to use these, improve cognitive functioning, right? Look, memory again, look, attention again, concentration again, and what? Visual spatial? I'm sure your visual spatial will improve if your memory, attention, and concentration improves, right? Okay. Slow symptom progressions. While not cure, it can delay worsening cognitive and function decline, although patients maintain independence longer. Enhance daily function. Patients may show better performance in activities of daily living, such as managing tasks. So diffuse traumatic brain injuries, damage the acetylcholinesterase inhibitor, the cholinesterase network, boom, hypoactivity. Alzheimer's disease, same process, mechanism different. Traumatic brain injury due to trauma. Alzheimer's due to the buildup of those like inclusion bodies, right? And they kill the cell. Let me see. Let me look at, we're going to go to a different neurotransmitter system. Let's say Parkinson's dementia is primarily dopamine in the basal ganglia. But let me see the impact, this relationship between that acetylcholinesterase muscarinic network and Alzheimer's in Parkinson's dementia. Okay, explain the use in Parkinson's dementia. Okay. Because remember, the movement disorders, the sort of the mass spaces, the stiffness and things like that, the shuffling gait and the postural instability and things like that. But I'm sure the cognitive functioning is diminished also. So even in patients with Parkinson's dementia, where the disease process involves a different neurotransmitter, particularly dopamine, I think we still have to consider acetylcholine, because you still have the diminished cognitive issues seen in Parkinson's dementia. And how are you going to address those? So here, explain Aricept use in Parkinson's dementia. Aricept is a cholinesterase inhibitor. We got that. But it's used off-label in cognitive symptoms in dementia, a condition where individuals with Parkinson's disease develop dementia characterized by memory impairment, executive dysfunction, and difficulties with attention and visual spatial. Right? Mechanism still works by inhibiting cholinesterase inhibitors. The utility still cognitive benefits. Okay. Functional behavior and symptom stabilization. Okay. So, of course, it's off-label, but if your patient comes in with those noticeable cognitive deficits, you're still going to have to do something to help them with attention and concentration. And this is one of the reasons why I use it. Let me see. Let's see, what else can I look for? This, I think that's it. So now you would see the indications why we would want to use target this acetylcholine muscarinic network. Now let's look at the actual network and let's see how it functions. Okay. So here, overview of acetylcholine and muscarinic receptors. Okay, so they take these two at the same time. So they take the acetylcholine, they address acetylcholine and muscarinic receptors at the same time. Okay. Acetylcholine is a neurotransmitter widely used in both the central nervous system and peripheral nervous system. All right. It interacts with two main types of receptors. Okay. The nicotinic receptors and the muscarinic receptors. These are ionotropic, right? Metabotropic, right? These are ligand ion channels, right? These are G proteins. And and then look, slower mediating modulatory effect. Now, you see that strategy also where each fiber system, whether or not it was the mesocortical pathway, or was a mesolimbic pathway, or remember the pathways in the basal ganglia, it was always a combination of receptors that operate ligand gate ion channels, and then another population of receptors that actually modulate the G protein receptors, right? And here we see the same pattern on the acetylcholine muscarinic sort of network. You see the receptors that target the gates, and then the receptors that target the G proteins. Here's why that's important. The gates are responsible for their signal transduction, propagation of the action potential, right? And the metabotropic, that's the ionotropic, right? That's the fast acting to get a response right away. And it also sets off that action potential to send that signal down to the terminal, the other end of that neuron, to tell them to release the gates, release everything that's been stored up. So that's one way that receptor gets its products exited out of the cell by the signals that goes along for the action potentials. The other group of receptors, the muscarinic receptors, metabotropic receptors, are the G proteins. Now, remember, the G proteins is the signal transduction cascade when the molecule target attaches to the ligand on the G proteins, which are usually huge 7-unit trans-phospholipid bibrain layer spanning molecules that convert their 3D configuration, which results in the 2 subunits breaking off and they become active and start creating things, right? So this muscarinic receptor is eventually going to send a signal to the cell body to create a product that it's going to eventually export. And to create that product, it takes a while. It takes some time to create that product. The action potential is long gone by the time the product actually exits the cell. And it can produce, so these G proteins can produce products that secrete things from the cell, in a very rapid filler, or activate other type of channels and receptors. This network has those 2 type of properties: the collections of gates and then the collections of products that we like to create. The muscarinic network specifically involves the muscarinic receptors, which are named after their sensitivity to muscarine, a product derived from certain mushrooms. Okay. These receptors are found in various tissues, including the heart, brain, smooth muscle glands, and autonomic ganglia. Great. Number 2, the types of muscarinic receptors. Okay. Mechanism of the muscarinic network. Let me see. Function of the muscarinic network. Neuroanatomy. Okay. I don't think I'm going to go through the neuroanatomy. The pharmacological relevance. I don't think I'll go through that. Modulation. The muscarinic network is tightly regulated. Acetylcholinesterase breaks down acetylcholine in the synaptic cleft, terminating the signal. Feedback mechanisms from the muscarinic 2 and 4 receptors on the presynaptic cells act as autoreceptors, inhibiting acetylcholine release to prevent overstimulation. Wow. Okay. And then crosstalk. Muscarinic receptors interact with other neurotransmitter systems to fine-tune neuronal activity. That makes sense, right? So in order for regulation, if we want to increase the activity of the muscarinic network, then we release acetylcholinesterase. It breaks down acetylcholine in the synaptic cleft, right? No, it causes. Let me move over here. I'm getting confused there. So let me go back up here. Okay. So let's look at the types of muscarinic receptors. There are 5 types of muscarinic receptors, 1 through 5, each with distinct distribution, signal mechanisms, and functions. They are classified based on their coupling to specific G proteins. Wow. Okay. So 2 types. And then it's always like that. Remember, like the types of dopamine receptors and everything. And then remember the type of like the serotonin receptors and things like that. And inside that family of receptors, there are some that activate things, and then there's those that deactivate things. There's another pattern you'll see here with every neurotransmitters, that they're divided into activators, modulators, or inhibitors, and you see the same thing here. And sometimes all the details like M1, 2, 3, 4, it can be overbearing, but to remember, but just understand that structure is there. The ones that activate the receptors and and they're all clustered together on the network. 135 GQ coupled. These receptors activate this G protein pathway. It increases intracellular calcium, and it activates protein kinase C. They are generally excitatory, right? Now, M2-4 are these couple receptors. The receptors inhibit adenylate cyclase, right, reducing cyclic AMP levels, and can modulate ion channels, particularly calcium channels. They are inhibitory. So the 2 type of muscarinic receptors. Okay, so let's see where they're found. Okay, so there are two of these. Let me just see where these are found first. 2 and 4. 2 and 4 found in the heart, the slow heart rate, slowing the heart rate, I can imagine. CNS, small muscles, highly expressed in the autonomic system. And 4, okay, so it's found in the heart, and 4, primarily in the CNS, involved in modulating dopamine release and motor control. So, wow. So this is where the muscarinic network starts to influence this dopamine network. Remember? So I think that's we see some of those improvements too. Remember in some of those hypodopaminergic states, like Parkinson's dementia, we also see them get better when we give them Aricept. And I guess here the Aricept results in release of more dopamine. I guess the Aricept indirectly can improve the dopamine release. I guess that's the mechanism. It's very interesting to know that. Okay, here 1, 3, and 5, they activate the pathway and increase intracellular calcium, and this activates protein type C. So 1, 3, and 5, predominantly in the CMS. Okay, yeah, look, the cortex, hippocampus, and striatum, involved in cognitive functions such as memory and learning. Okay, so this is where the muscarinic activates it here. Very interesting. Found in the heart. Okay, we did that one. 3, present in smooth muscles in the GI tract, brachial tissues, glands, and the CNS is involved in smooth muscle contraction in glandular tissue. Remember, one of the side effects of Aricept is drooling, running, all things running, drooly mouth. You see salivary glands, runny nose, and things like that. And this is one of the side effects because it hits these M3 GI receptors involved in smooth muscle contraction. Okay, then we have M5. It's less abundant. It's found in the CNS, substantia nigra. Hey, an abundant vascular endothelium plays a role in dopamine regulation and vasodilation. I guess this M5 is very important, particularly substantia nigra. This is where Parkinson's dementia, this is where the pathology is at. So when using Aricept and that for the cognitive benefits, I can see this is why. It's through the M5 receptor. Okay, now let me see. Let's see. I don't want to go too far into some of this. Okay, I think a mechanism is okay. Okay, mechanism, yeah. Okay, the muscarinic network operates through the interactions of acetylcholine. Okay, great. All right, or the acetylcholine muscarinic network triggering intracellular signaling cascades. Okay, great. So these 1 through 5, okay, they activate the protein. Yep, and 2, 4, okay, they inhibit it. Okay, we got that. Okay, let me see. Functions of muscarinic network. The functions of the muscarinic network modulates a wide range of physiological processes in the CNS with cognitive and memory. Yep, motor control, receptors in the basal ganglia. Okay. Yeah, so muscarinic, wow. So yeah, so they're located throughout the basal ganglia. I never really read too much about the acetylcholine receptors located in the basal ganglia, but I guess in motor control, this is very helpful. Influencing movement and coordination relevant to Parkinson's disease, right? Sleep and arousal, muscarinic receptors regulate sleep, wakefulness, and REM sleep via cholinergic neurons in the brainstem and forebrain. Okay, then we have the peripheral nervous system. Okay, it mediate parasympathetic effects. Okay, slow heart rate by inhibiting pacemaker cells and promote contraction of GI motility. Okay, I think that's it. I think that's half for now. Okay, and then let me see if I have any questions. Okay, and we're at 25 minutes now. I didn't want to go too far into this. Let's see. Let me have a question here. Hey, T-Jam, thanks for the question, buddy. Did Muhammad Ali suffer from a TBI? I think so. A diffuse traumatic brain injury, multiple ones. Was he on Aricept after his injury? I would think so. You know, Aricept's been around for several decades, and so I think they would have definitely had him on there. Okay, guys, I hope this is helpful for you guys. And so now when let's say, hey, iHash guy. Thanks, iHash, for the question, buddy. Why do Alzheimer's patients often have a disrupted acetylcholine system? You know, because it has a predilection, the pathology has a predilection for cholinergic neurons. And so you get the death of cholinergic neurons in Alzheimer's dementia. And that's when you get all the cognitive problems that we just read about, right? Okay, so it's at 26 minutes. I'm going to go ahead and call it for today. If you have any other questions for me, in the chat for me, I'll get to them if I can. Stuff, but other week, read out. You guys take care of yourself. Yeah. Today, we're going to go over serotonin receptors. Serotonin is very important. Very important. You know, every time I think of the new neurotransmitters, it seems like when they're in excess, they present with a certain type of symptoms, a certain symptomatology, certain patterns, you know. And when the same neurotransmitters are diminished, they present with another presentation and more of the withdrawn phase of that disorder, right? So remember dopamine, excessive dopamine, right? Psychoticism, delusions, and sometimes delusions are very uncomfortable to think about, you know. And when excessive dopamine, you sort of think about a horror story, right? Excessive dopamine sounds like a horror movie, right? And excessive norepinephrine is more like when you hear the at the end of the Super Bowl, right when they win the Super Bowl, hey, 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 where you going after the Super Bowl? I'm going to Disney World, right? That's like what I sort of like think about stories when there's excessive amounts of norepinephrine, and then I start thinking things like mania, right? Mania, you know. Um, and again, it may not even be mania. It may be that the person is simply mismatched with the environment at the time. And the people who are slow are referring it to as mania because it makes them feel better. But when you think about excessive norepinephrine, think about mania, you know. And then here we're going to do the one on serotonin, excessive serotonin, love, things like that, right? Affection and things like that, falling in love, you know, the sense of warmness, you know, sense of oneness, unity. And of course, low level of serotonin, depression, and anxiety, right? So we're going to go over the serotonin receptor, and let's see here. So I have here. Okay, let me see here. Or is this one better? This one's bigger. That's big. Good. Okay, how about this one? Okay, so this is just a free grok, and you can use anyone you want. Explain serotonin receptors. Okay, let's see what we get here. I hope I'm connected. Let me turn a little music off here. Okay, let's see. Explain serotonin receptor. Look, distribution here. Serotonin receptors are found in the central nervous system, the brain and spinal cord. Also in the peripheral nervous system, other tissues like the gut. Remember, you give SSRIs and things like that, they can have like GI upset right there. Blood vessels, remember lightheadedness, dizziness, hypotension. It can cause those as side effects. Changes in your cardiac arrhythmia, things like that. Okay, the various locations explain, the various locations explain serotonin's wide range effects. Okay, so that's why this is the distribution to other tissues is one of the reasons why you get side effects and why they present the way they do. So whenever I give patients with these SSRIs, watch out for any lightheadedness, nausea, vomiting, or dizziness, things like that. So let's get into it. Okay, so serotonin receptors are a group of proteins found on cell surfaces that bind to serotonin, right? 5-hydroxytryptamine, okay, or 5-HT. The neurotransmitter involved in regulating, mood, sleep, appetite, memory, and other physiological processes. Remember appetite. So these receptors are responsible for these like domains of functions, just like mood, right, sleep, like appetite, like memory, and other physiological processes like weight gain and things like that, energy level, interest, and things like that. But isn't this all of the symptoms of depression, right? When you ask someone about depression, don't you ask about mood? How are you sleeping? I'm not sleeping well. I can't fall asleep, or it takes too long to fall asleep, or I'm sleeping too much and really tired. Memory, hey, it's impacting my memory. I can't think about things, and other physiological processes like weight loss or weight gain, things like that. So you can see the symptoms of the SIGI caps. I guess the symptoms of depression are basically attached to the domains of things that this receptor is responsible for. So these receptors are critical for maintaining serotonin's effects on the body and brain, right? Okay, there are 7 main families of serotonin receptors, H1 through 7, with multiple subtypes, 5-HT1A, 5-HT2B, things like this, making at least a total of 14 known receptors. Right, okay, so there's at least a total of 14 known serotonin receptors. Okay, each play a distinct role in location, distinct role, then they're located at certain locations, and then they have slightly different mechanisms. So I don't want to go into the details of this, but let me just go through the distribution here. So these 5-HT1 receptors are generally inhibitory, right? And reduces neuronal activity. Okay, look at this one. I think it's 518, which is the other one. Yep, okay, 5 right here. And 5-HT5 receptors are also inhibitory. So the inhibitory receptors, if I can remember correctly, HT1 and 5. So these are all inhibitory, and they decrease neuronal activity. Less understood, but likely inhibitory. Okay. Now, the H2, the other receptors, excitatory, increase neuronal activity, causing the fast excitatory response. Okay, 4, stimulatory, enhances GI cognitive motility and cognitive function. Excitatory, 5, inhibitory. And I think the 6, is it excitatory too? Yeah, I'm not sure about this one. 7, excitatory. So remember, 14 total receptors, 2 categories, 1 and 5 are like inhibitory, the other ones are sort of excitatory. And so if you're thinking about if someone presents with depression, a significant amount of anxiety, sort of think about these serotonergic networks being somewhat hypoactive, right? And so we'll need to sort of activate these networks, and so they're more active and we get more transmission. If we get more transmission across these networks, then the lobe is carrying out its responsibility, better, right? Okay, so here, those are the two types. Okay, so remember we were same thing with the receptors and the networks and the proteins, all that. Two types, the ion gated channels, and then the G protein channels, the ionotropic and metabotropic sort of pathways. Here it is here. The duality presents right here also, because you see the G protein receptors and ligand gated ion channels. So G protein receptors, most serotonin receptors, 3 are G protein receptors, right? So remember, around 14 of these receptors, at least 14 of the receptors, most of the serotonin receptors, except 3, are G proteins, which trigger intracellular signaling pathways, including cyclic AMP or calcium release when serotonin binds, meaning it alters the cell functioning. This is very important because remember, the ion-gated channels are important in the signal in initiating the action potential, and that form of communication that almost happens instantly. But then the G protein is this is the process that allows the signal transduction pathway, and that's where we're going to actually create a specific message for the cell body to produce a product. And when it says altering gene function, when the serotonin binds to the receptor, it goes through the signal transduction pathway and produces a product that's then exported from the cell. Then that's when you get an alteration in the cell function. Ligand-gated channels, these allow rapid inflow of sodium across the membrane, causing immediate neuronal excitation. So here, okay. The physiological and clinical relevance, mood and mental health. 5, 1, and 2 receptors are key targets for antidepressants. Okay, 5-HT1A, 5-HT1-2, they increase serotonin availability, right? Great. 3 and 4, GI. Okay, 6 and 7, neurological disorders. Many drugs, including psychedelics, migraine medications, sumatriptans, and antiemetics, target specific serotonergic receptors. Makes sense. Okay, distribution. Oh, we got through that pretty fast. Okay, and let me see if you have any questions now. Just ask any questions if you have it. So this is for the serotonin receptor. Okay. We look at the serotonin molecule. I will see if we can do that. I won't be able to go through this. I remember organic chemistry. Okay, let me see here. Even if I read this, I wouldn't understand it. so let me move on. It's so disconnected from what I do. I was hoping. Let me see if I can find a image of this serotonin. Okay, maybe this is the source. Okay. All right. Serotonin is also known as 5-hydroxytryptamine. Has a molecular formula here. Features 5. Okay. Yeah. This is okay. Yeah. Let me skip that too. Okay. Let me review the SSRI medications. Okay, I don't know if that's. I meant SSRIs. Okay. Okay. So um, we use SSRIs for the primary treatment for major depressive disorder, depressions, and anxieties, and it's believed that it's hypoactivity in these networks. And so we use a category of medications called selective serotonin reuptake inhibitors. These basically turn off the reuptake pump that's located on the presynaptic cell. When you don't get as much reuptake of the serotonin from the synaptic cleft into the cell, then more of the serotonin, the tighter increases in the synaptic cleft, and the larger the titer, then hopefully we can increase the transmission. So that's the thought, the thoughts behind it. There are classes of antidepressants that work primarily by blocking serotonin transporters, which increase serotonergic level in the synaptic cleft, enhancing serotonergic transmission. This mechanism helps alleviate the symptoms of a major depressive disorder, anxiety disorder, look, OCD, PTSD, and other conditions. SSRIs are considered a first line treatment for depression due to their efficacy, relatively favorable side effect profile, and lower toxicity compared to tricyclic antidepressants and MAOs. Mechanism here. SSRIs selectively inhibit serotonin reuptake with a minimal effect on other neurotransmitters, reducing side effects compared to less selective drugs. They primarily interact with serotonin receptors indirectly by increasing available serotonin, which then activates receptors like the 5-HT1A and the 5-HT2A. Okay, so it's approved for major depression, generalized anxiety disorder, social anxiety disorder, panic disorders, OCD, PTSD, and also premenstrual dysphoric disorder. Side effects: lightheadedness, nausea, vomiting, dizziness, some sexual dysfunction, decreased libido, possible weight gain, typical side effect profile. But look, side effects: SSRIs different half-life. A metabolism is via the cytochrome P450 system, mainly the 2D6 and the 3,4-A pathways, and drugs, and interacts with potential drugs. Yeah, see, Prozac has the longest half-life is days to week. They even have a tablet like called Prozac Weekly. You take once or more. There are some versions that have a half-life less than 24 hours. Okay, so here's another thing that you may want to find interesting here. This is a list of SSRIs ordered by potency, right? The strongest ones first. Because if you're in an outpatient setting, if you have someone with like a major depressive disorder, but it doesn't seem to be maybe on the mild to moderate spectrum, then you want to use the less potent ones. And for the ones that may experience treatment refractory or things like that, or if their depression is mediated by something other than serotonin, then you may want to go with one of these stronger, more potent SSRIs. So here, Paxil, I mean, this is really Paxil is very good medication. It works very well. It's a very potent medication. We give it at night because it can lead to some sedation and dry mouth. It's used for major depressive disorders, OCD, particularly OCD, and PTSD and things like that. 60 milligrams a day, half-life less than 21 hours. Yeah, you have to prepare your patients with Paxil too because it can cause a lot of anxiety when you're starting it. Zoloft. Okay, here's the Ki. The affinity here is 0.13, 0.29. I don't know what that is. Okay, then we have Celexa, right? Escitalopram, Lexapro, right here. Fluoxetine, Prozac. Yeah. Luvox, citalopram. Yeah. Celexa, one of the weakest ones, right? Paxil, one of the strongest. So look, Paxil, Zoloft, Lexapro, Prozac, Zolin. Well, now the atypical. Well, let me look at the atypical things later. And I think that's all I wanted to do for now. We went over the serotonin receptor, tried to go through the molecules, diagnosis. I think that's it for now. Okay, guys, I think that's all I'm going to do for today. I'll leave it there. We're at 20 minutes. I don't want to go too far over 20 minutes. But if you have any questions for me, please leave them in the comment section. And please like, subscribe, and share. Read out. It's been a pleasure, guys. Take care. Ciao.